Okay, good afternoon. This is Dr. John Bennett, broadcasting from Miami, Florida. Tonight we have another in the weekly neurosurgical TV series, and today we have the pleasure of having Richard Mendel, the spinal neurosurgeon from Tampa, who's done the last couple of weeks. And today, Dr. Mendel is going to talk about localization of spinal lesions and tracts. And first, we'll introduce the panelists, and then we'll turn it over to Richard. So why don't we start with you, Ben?
Yep, I'm Dr. Mulpuri from Saginaw, Michigan. I'm a internal medicine physician, and I've been involved with Dr. Bennett for a while, and I love these hangouts, and I'm so happy to have you here today.
Welcome, Ben. And Simon?
Hello, everyone. My name is Simon Downs. I'm a clinical psychologist in Japan, also a medical student, and very interested in neurosurgery. Thank you very much.
Yeah, he's a gold star member of this board. And Lisa.
Hi, I'm Lisa Cornforth. I'm an RN and I live in Arkansas, and I'm a second-year medical student at OUM.
Okay, welcome, Lisa. Eleonora.
Good afternoon. My name is Eleonora. I'm a final year medical student in Rome, Italy, and I've been an intern in the neurology department since November 2013. So I'm happy to be here.
Buongiorno. Andres pulled that one last time. Andres.
Hi, good afternoon. My name is Andres Alvarez. I'm clinical fellow in Miami Neuroscience Center. I'm doing neurological surgery, oncology, and minimally invasive spine surgery. Thank you for the invitation.
Welcome, Andres. Okay, Richard, it's your show. Take it away.
All right. Well, Andre, this is going to be way beneath you, but what we were trying to do is go through the neuro exam just to get an idea of how to localize the examination to cranial versus spinal. And what I found this week, because Dr. Bennett had been speaking about the Gilman and Gilman, was that, or Sidman and Sidman tracts, and that's an older textbook. It was very good, but I found some stuff on the internet today, the last week, that was really much better than anything I remembered from medical school. So let me start out by, we'll just talk about what we're trying to do today. I wanted you to be able to kind of visualize the different tracts from sensory, ascending tracts from sensation to ascending tracts from motor and reflexes. And now it's being done so well by one particular artist who I thought was great, and you'll have the link to his site in a few minutes, but I've never seen presentations with this before. In medical, after another, and a lot of times you try to learn things without understanding things, which is basically memorization. And memorization is fine for details that are difficult, but the basics you want to know very well. So here are the presentations I saw that was really excellent. Let's see. Just one second. Okay.
It's a localization slide.
So, like I said before, building blocks, and this was my own suggestion for not wasting time when you're studying, is to go from global to granular. Look at the tree trunk first, without leaves, without everything else, and get an idea from there. So you want to try to learn something and understand at the same time. I used to have a junior staff person when I was a resident, and he was great with mnemonics. And it almost seemed to me like he had like I would ask him a question, and he really didn't understand the question I was asking him, and he would just come up with a mnemonic from residency, like fat girls eat donuts, and that's how he remembered the nuclei in the cerebellum from the fastigial, globiform, emboliform, and dentate nuclei. And you know, it was almost like he had, you know, he could remember, that's all. And I think the line drawings that you see in a lot of texts, like Ed Benzel would say this too, the spine textbook, you know, he wanted line drawings for when you were first learning things, and then the more detailed stuff you get to. This guy is really incredible. Now, this is Armando Husendungen has this website with biology and medicine videos, and what he does is start out drawing a neuron, and then he shows you how to brain all the signals that go through it. Then he talks about the spinal cord tracts, and he draws them all for you in nice line figures, so it would be very easy to understand. So I have the link here for you, and I really think that's much better than listening to me. Just look at the particular tracts, and remember, you know, the tracts are different for in research than they are for the human exam. Like in London, in Queen Square, that they would always, one second, I got to plug this in. In London, they would always talk about the rubrospinal tract, and I never really understood what it did. And what they had done was, years ago, they had this primate lab, and they actually lesioned the rubrospinal tract in a bunch of baboons or primates. And what they found was that the way they fed them were these pellets, and there were all these grooves in the floor, and the primates that had the rubrospinal tract cut actually couldn't pick up the pellets that they fed them with in the laboratory. So, but in humans, they're not important. It's not really that important. But, you know, you get a lot of distinctions. But when this guy draws out the diagrams for you, it's really very good. Now, you'll be able to click right to here, and you'll get a menu, and he will show you, he'll draw the different tracks for you, much better than I could do it. And, you know, these are the fiber tracks that you're going to see in Tractography, and well, I'm still having.
You're trying to change slides, Richard?
Yeah, this time my computer the desktop's just much more crowded with a lot of menus popping up.
Okay.
In the way of the slide presentation. Here's the next. So this other person is Dr. Najib, and he does a lot of lectures for medical students, and his lectures are very good too. And again, he just does the line drawings that I think are a lot more valuable when you're trying to learn this. And you know, he draws out many of the same tracks, and he does not only neurology but everything else. The first link I gave you, this guy has like a complete portfolio of all these different tracks, and he does everything as well, not just neurology, but he's really good at the neurology portion of it. So, you know, I was trying to think of how you want to get the localization of spinal nerve and root lesions. And so, when you're just learning these, it's a good idea to kind of just start out very general. And like if you can look at a spinal cord grossly, or at least the diagram of it, you could make a few really basic observations. Like you look at the cord and you see where the cord widens, and that's where your extremity roots come off. Those are expansions in the cervical spine and in the thoracolumbar spine, mostly the lumbar sacral spine, I'm sorry. The roots that you're going to see in clinic that are going to be most common are going to be the expansion. Like the C5 nerve root is unusual in that it is the only nerve root that innervates the deltoid. So every other muscle in your upper extremity has two nerve roots going to it except the deltoid, which only has one. That's C5. So, a C5 retinopathy is something you have to pay attention to, because if that muscle atrophies too much, the person doesn't get much deltoid strength back, and it's hard to build back up. So a C5 nerve root lesion is something you want to be cognizant of. The other variations that happen in the cord are that the gray matter is most dense the closest it is to the brainstem, and the white matter is most dense low down in the lumbosacral spine, where you have less and less of a gray to white matter ratio. Whereas if you go up the spine, you have a much greater gray to white matter ratio. Now, this is really important for the students when you're talking about spinal cord localization. This diagram always seems to appear in your qualification exams before residency, when you're graduating from medical school. This is a complete lesion of the cord, complete transection. This is a Brown-Séquard syndrome, where there's a hemisection of the cord, and so you're going to have both ipsilateral and motor findings. And your ability to identify, just to understand these different patterns of disease, really helps you think through spinal cord anatomy. Like here is an example of syringomyelia, where there's a small syrinx, but as it expands, you get a lot of what's called sensory dissociation, and that just is related to the tracts, that get involved. Now, here is a posterior column syndrome. This is something you saw often in things like neurosyphilis, where the dorsal columns were primarily involved. Here is ALS, or motor neuron lesions, and this is a combined horn cell and posterior tract syndrome, and this is an example of an injury to the anterior spinal artery, where you're just left with posterior column function. Now, I think if we go back to slide 3, let me try to get this link for you. Let me go right to his menu.
Okay.
It's opening up a different box. Are you able to see the box it's opening?
We'll see the excellent free resources available online.
Are you able to see this diagram or not really?
Not yet, no.
Well, I'm getting the full link here and the menu.
Okay.
Can you see the subject list? You can't see that.
No, not really. We see the link is about it.
All right. Well, you're going to be able to click on that link, and it takes. The problem is that another tab opens.
Okay.
Let me see if I can include that, though.
Okay.
Yeah, I'm not sure how I'm going to be able to include this, but you'll be able to see it. It's just a matter of going to YouTube.
Okay, well, we can send it to everybody after.
See, I have a movie playing now. You can't see that, can you?
No, no, we can't. Well, you might have to exit that screen share, Richard, and start another one. Maybe that might work if you want to try that. I can hear you probably watching it now.
Yeah.
Or we can just send the link for people to watch later. Okay.
Are you just still seeing the spinal cord diagram?
Yeah, spinal cord localization, yes.
Okay. Oh. All right. Well, I really think that these videos are going to be the best thing to spend your time on, because when this guy draws it out, he's really very talented.
Okay.
And this is the best video demonstration I've ever seen of basic neuroanatomy.
Okay.
I just happened upon him this week.
Okay. We'll be sure to send it to the students.
Jeez.
Oh, Richard dropped off. Well, Andres, I'd like you to meet, and the rest of the panel, Daniel Ochiang. Hi, Daniel.
Nice to meet you.
Hey everyone, it's been a while. Glad to be back.
Yeah,
Hello.
glad to have you back. I'd like you to meet, first of all, Andres to your left. He's a neurosurgeon from Miami.
Hi Andre.
My pleasure. Welcome.
And the rest of Eleonora, say hi to Dan from South Africa. He's a neurosurgeon in South Africa.
Hi, Dan. Nice to meet you.
Hey Eleonora, nice to meet you too.
She's from Italy, Dan. And Lisa, we want to say hi to Dan?
Hi, Dan. Welcome. I'm glad you're able to join today. I'm a medical student at Oceana University of Medicine. I'm a second year, and I live in Arkansas.
Okay, welcome. Okay, Simon, say hi to Dan.
Hi Dan, I'm Simon. I'm in Tokyo, Japan. If you're ever in my neighborhood, please.
Next time in Tokyo. And
Yes.
Ben?
Hi, Ben. Hi, Dan. Sorry. Hi, Dan. I'm Ben from Michigan. I'm a physician. I'm glad to see you on this Hangout. Glad you're here.
Thanks.
Nice to have you. Thanks.
Yeah, I guess. Well, we're waiting for Richard to come back now. But Dan, you've been very busy lately.
Yeah, it's been a crazy couple of months, but finally things are all sorted out.
Oh, good. What were you doing? Extra duty or?
Yeah, some extra duties and exams. It's been a couple crazy getting board certification and stuff all sorted out. But finally now it looks much better, and hopefully I'll be a regular on the show every weekend.
Oh, great,
Oh,
great.
nice.
You know, Andres works in. He's doing a fellowship now in Miami. Could you tell Dan about what you're doing in Miami, Andres?
Wow, we have some experience in gamma knife, so I'm training in gamma knife radiosurgery for brain tumor, for trigeminal neuralgia, and actually we're doing endoscopic approach for pituitary tumors, craniopharyngiomas, and actually we're doing some treatment for endovascular too. So we have like a kind of fellowship in all of the neurosurgery. So we have the machines, sometimes gamma knife, sometimes minimally invasive spine surgery. So we are pretty busy, but I'm happy. It's a good experience.
Okay, and you've done your residency, correct, Andres?
Yeah, I doing here a clinical research fellowship. So I did my medical school in Colombia.
Okay.
Then I moved to Italy. I got there my grades, and then I came to the United States. So I'm doing my boards too.
Oh, okay. So, Dan, did you finish your boards, or you just took your boards?
Yeah, just took my boards, just finishing up. But yeah, it's interesting listening to Andres. Like for trigeminal neuralgia, impressive the stuff you're doing with Gamma Knife. Actually had 2 cases over the last 2 weeks, but we still do a lot of glycerol rhizotomy for that. It would be interesting to catch up on the sidelines and just share some ideas and exchange some ideas on some of the cases you see.
Well, Dan, we'll talk about that later, because I may be working with Andres' hospital to help publicize the Gamma Knife with Dr. Wolf, who has done 6,000 Gamma Knife surgeries. So we'll certainly involve you in that.
Definitely, that would be great, John.
Richard, welcome back.
Yeah, well, I think this is the interface between the slides and the chat, but all the links that are on there are easy. Just go to YouTube, and these people really do a great job. Okay. So I don't think you need to listen to me describe the tracks when they can draw them out so well.
Okay. Well, why don't we just open it up for some questions? Do you want to do that now, Richard?
Yeah, sure.
Yeah, okay. Do you guys, especially the students, I'm sure the neurosurgeons, this is kind of old hat to them, but Simon, Lisa, and Eleonora, do you have any specific questions for Richard? Hello?
I just want to thank him because I knew about Dr. Najib lectures, but I didn't know about Armando. So I'm watching some videos, and yeah, they are incredible. So I definitely want to look at them to learn.
Yeah, really.
I didn't know him, so thank you.
No, it's not that I'm lazy. Honestly, I went through this. There's no way I could do as good a job as this guy does.
Okay, well, I got to look at those, man. They sound good.
Yeah,
I would look at them. Ven just put up a message that the artist was amazing. He really is.
Yeah,
I've never seen it before.
Dr. Najib?
Yep. Whoever it is, but he's
so you know who he was, Ben?
No, I don't know. I mean, I just saw the videos right now.
Oh, okay.
Yeah.
Okay.
Just open one. Explain
Najib has like a command of every specialty. He could draw out anything.
So perfect.
Is he like the Frank Netter of neurosurgery? Do you know who he is, right, Simon?
Yes.
Is he like the Frank Netter of neurosurgery?
Yeah, I know him. Yeah,
he's an Indian oncologist.
No, he's not Indian. He's from Siba.
Pakistan.
I mean, he used to work for. No, not Frank Netter.
No, not Frank Netter. I mean, where is Dr. Najib from?
I don't know.
I think he's in Lahore in Pakistan. I think he's
could be. It sounds like something like that.
Yeah. Wonderful guy, very friendly guy too. You can contact him directly. He'll write back to you.
That's good.
Yeah.
Okay. So, any specific questions? Otherwise, we can just end the session and do some networking.
I just have one quick observation.
Go ahead, Simon.
It's probably a very simple one, but I hadn't considered that in places like Nepal or in Haiti, where they don't have access to MRI or CT sometimes, and that the neurological exam was going to be all they have. And so I really started to think, wow, this is really important to do right. I'm wondering how far you can go and how well you can do the neurological exam that you wouldn't need it.
I think you can go really far. One of the things they told me when I was going to London doing neurology when I was a resident was, my chairman said, see how much they do with so little, because it was rare to order a CT or an MRI from clinic, because you had to examine everybody, and they just don't rely on so much in the way of technology.
Right.
And the technology is great, but it's not a substitute for understanding everything. A lot of people that don't know anatomy really well think like, oh, that's okay. I don't have to know this anatomy that well because I'm going to have image guidance when I do surgery. Image guidance is great for people to understand anatomy, but image guidance doesn't make up for a lack of anatomic knowledge. I mean, you really have to understand, what you're doing. Like, Simon, this isn't so, it's not hard. Like you said, oh, well, what would happen if I'm on the floor and somebody starts asking me questions about the lumbar plexus? Well,
Yes.
It's not how it's going to happen. In medical school, you're going to learn the brachial plexus as well as you can. Then you'll get to the lumbar plexus.
Mm-hmm.
And then when you're in class, you're going to see that plexus problems are an issue, but they're not as common as nerve root syndromes. And you're going to learn the important,
Whoop, we lost him.
Wow.
Let me just ask a quick question to Dan and Andres. Well, what kind of lesions would you typically treat in the spine besides a protruding disc? Are there any other lesions you guys treat?
If you could take that question, at least from the South African point of view, there's a lot of trauma. So in as much as things like Brown's acquired, we see a lot of penetrating injuries to the spine, a lot of gunshots, and a lot of knife stabs directly to the spine. And it's actually a beauty when you're able to relate when the patient comes in with hemisensory loss on the opposite side, when they come in with ipsilateral loss of power and sensation, and it just clicks and lights up that bulb in your head, and you know that this is what this patient has. And then one of the things you learn as you go through medical school for the medical students, you learn that it's not just about cramming it for the exam. It's an everyday skill that you'll need to do. And one of my professors used to say that 65% of your diagnosis should be able to come from your clinical history taking and your exam. When it comes to the imaging and the lab, it's just to confirm what you already know, and that way you're able to order.
Yes, this is what they say to us. This is what they say us. Yeah, this is what they teach us. 50% of your diagnosis is made up from your history and examination, and then
Yeah, that's the most important way, the semiology. So you know where's the dermatome, what is the symptoms. Actually, we have many cases here. We don't have too much trauma, but we have a Cauda-Equina syndrome, so you need to know the diagnosis just with the symptoms. And another kind of thing that we have a lot is cervical stenosis. So it depends on what finger the patient feels numbness, you will know where's the lesion. So that's the most common problems in that type of patients.
This is for Dan and Andres. Is there any situations where you operate just based on your physical exam and history because you're not near any imaging studies? Or do you always wait to get some imaging studies to confirm your clinical suspicions?
Well, in America, we need the studies first. We need to ask for X-rays and MRI.
Right.
Yes, 100%.
Right.
Because of liability.
Yeah. I know the USA is like that. Is it like that in South Africa too, Dan? Where you have
It depends on which part of South Africa you are in. Cape Town generally will get imaging at any time. But then it also depends on the acuity. So when dealing with Cauda-Equina syndromes and patients who present with sudden deterioration, for example, post-traumatic, and you see them and later on they have loss of power and you think maybe they have a hematoma, there are certain cases where we've had to take the patients directly into surgery without having to image them, especially when you think they have a hematoma that you can do something about.
Right.
So it depends, but generally we get imaging on everyone. But if you are in over the night or over weekends in emergency situations, you maybe have to do exploration without any imaging.
Yeah, in Colombia, for example, we don't have MRI 24 hours, and we don't have a CT scan 24 hours. So we need to ask for an X-ray, and if we see any fracture or in the patient with symptoms, we have to go to OR. Absolutely. Right. But here with the technology, we just ask for CT scan, and then we will see what we need to do. But we treat symptoms. We don't treat image. That is very important. because sometimes the MRI shows some problems in the right side and the symptoms is more in the left side. So that's why we take the decision just first in the symptoms and then let's look the MRI.
Oh, okay.
Yeah.
There's Richard. Hey, Richard,
Yeah.
we're just talking about when a neurosurgeon may operate just based on his clinical findings. He may not be near a CT scan or an MRI, like you were talking about in England. They rely more on their clinical exam and history.
Well, yeah, but there they just order a much lower volume of things. I mean, you could get a CT scan if you absolutely have to, and in instances like trauma, that's not going to be a problem. They'll get you a scan, but you're not just going to be ordering scans on everybody in the clinic. Or when we were in Haiti, you know, there was very little technology. The only place we could get CT scans was for some babies that had hydrocephalus. They had a special program set up there to get the children that were, you know, viable scanned. But, you know, in London, they're not operating without imaging. It's just that they don't have thousands and thousands of MRIs that are basically normal. You know, here in the U.S., a lot of the radiologists, you know, read, you know, you'll find doctors that order MRIs for back pain when there's very little reason to order an MRI for back pain as a first study.
Right.
You know, you tend to order it for people with radicular pain or something like that, but you know, you don't jump to the MRI, which is the most sensitive test, when you're working somebody up with back pain. You might, you know, you get a plain lumbar spine film or something, but you know, a patient that has a radicular distribution of pain, that's reasonable. But you know, when I've traveled other places, like I was in the Czech Republic and even in Switzerland, they just don't order so many films. People tend to examine the patient more.
Right, right. Now, do you? This is a general question. The neurosurgeon takes care of the spinal cord. Do you guys go peripherally at all for nerve injuries, or that's the domain of the orthopedic surgeon? Or
no, I mean, peripheral nerve problems are something that I think orthopods handle a lot of, and there's 10 times more orthopods than there are neurosurgeons. So right. The vast majority is going to be probably being done by orthopods. But you know, the people that are big in the field of peripheral nerve surgery include people like Dr. Hudson and Alan Hudson, and you know, a lot of neurosurgeons are interested in peripheral nerve. The fellow at the Mayo Clinic now that is very good just published an examination of the peripheral nervous system. You know, things like nerve entrapments are common problems that you're going to see in clinic. And I think most of the time you're going to send it to whoever you're used to sending it to. There's often going to be more orthopods than there are neurosurgeons in the area. And you know, you have orthopods that really specialize in upper extremity or hand, and you know, they have a lot of different subspecialties. You know, some guys do shoulders, a lot of guys will do, you know, hand and upper extremity. But you know, when you get people that, I think orthopods do more peripheral nerve surgery, but I don't think, it hasn't been my experience that orthopods tend to do much plexus surgery. That right. tends to be mostly neurosurgeons.
Right. Well, you know, this is kind of a digital tech question, but nowadays cardiac surgeons are having a child's heart imaged by 3D printing, so that they know if there's any anomalous anatomy or unusual anatomy before they go in. Are neurosurgeons doing anything like that Richard?
Yeah.
Do you know about that?
Yeah, Dr. Spetzler has been doing 3D printer models of brain tumors.
Oh, okay.
Yeah.
Makes a lot of sense.
Yeah, to know what's there before you go in.
Yeah, we have the GPS, the neuro navigation.
Right,
Yeah.
right. Yeah,
Yeah, so with
GPS
that
of the brain.
GPS, everything coming fine, and it's more easy way to treat tumors, treat hemorrhagic things. It's pretty different, like a neurosurgeon 20 years ago. Now we know where we're going. Before it was just anatomy.
Right.
Yeah,
Right.
I mean, it's really, when you think back 20 years, you know, it's amazing how far things have come. And the other thing that I think is amazing is that, you know, the MRI tractography and the imaging of all the fiber tracts is incredible. But what's also incredible is, like, for instance, the guys at the University of Arkansas and that Arkansas neurosurgery group, you know, they do fiber tract dissections commonly, like at St. Louis University. They run courses on, you know, tract dissection. And the idea that we'd be dissecting out tracts is pretty, you know, it's pretty amazing. So I think we came a long way. I think the technology is great. But, you know, even as great as all the technology is, you still have to understand the simple parts of the exam. Because without understanding that, nothing else really hangs together that well.
Well,
you know?
well, you know, Richard, I think that's something that most students, including myself, when we trained, we were kind of wanted to order a bunch of tests before we really examine the patient.
Yeah.
It's kind of a habit you have to fight.
No, I know. But I'll tell you something, and this is awful, but 3 years ago, I was operating in a trauma center, and I got a phone call from the emergency room doctor who was 1 floor below me. And she's calling me in surgery several times. So I get on the phone with her, and she tells me that she has a spinal cord injury that's in the trauma center, and there's nothing I can do. Anyway, I'm busy doing surgery, and no one else, no other neurosurgeon was there.
Right.
And I asked her what the guy's exam was, and she said she didn't know. She hadn't seen the patient yet. She was just depending on what the nurses told her. So she thought more of calling me directly in surgery rather than even examining the patient.
Wow.
Turns out the patient I had seen the night before, he is a nice person who had a bad alcohol problem and was actually dying of end-stage liver disease. And he fell when he was drunk at home that night, because I had seen him for the compression fracture the night before, and they never got really much of a history. They just did another MRI. So he had 2 lumbar spine MRIs, you know, 36 hours apart, but nobody had examined him. So even though he's got 2 MRIs, so she says, "Well, I got an MRI of him," and I said, "You got an MRI before you even examined him?"
Wow.
She said, "Yeah."
Wow.
And I said, I looked at it on the PAC system, and you know, it was basically identical to the one 2 days before, and you know, it's amazing how lazy people can get. You know, all this technology doesn't make up for an exam. So eventually I go see the guy. He's, you know, she tells me he's paralyzed. He's not paralyzed. He's got a little bit of a weakness in his quadricep from femoral nerve compression, and you know, he's lifting it. The guy can walk around and everything else, but you know, nothing substitutes for an exam. You just, even though you know you don't want to get up and examine everybody, you want to at least take a look at them. Looking at the films doesn't tell you that much.
Absolutely.
Well, you know, Richard, I had a situation where we had to go to the imaging study because I was working with the jail system, and sometimes the patient feigned paralysis.
Oh, always.
And in order not to go to jail or not to go somewhere.
Yeah, at the University of Oklahoma, we always saw those patients in the ER but there were tricks you could do, like, you use your beeper and the vibration, or you would, the other thing you would do is, crack a vial of smelling salts right under their nose, because a lot of the patients that weren't
truly comatose, yeah.
Hadn't seen that before. Yeah, the guys were all. Yeah, I understand that when you're dealing with the prison system.
Right.
But I'm talking about, the average patient coming in with low back pain doesn't need to start off with an MRI exam.
Right.
So,
Point taken. Okay.
Yeah. That's sometimes that's a waste of resources also. I've seen in my residency, I was called to the emergency room. They said the CT was done, and the patient has nothing showing. I mean, the patient is supposedly have some infarction, and they didn't do the examination. I asked the patient to open the mouth, and his tongue was deviated to one side.
Yeah.
And sometimes in infarction, CT did not catch the things. Really, early stage.
I'm not criticizing. Just saying that sometimes.
Oh, God.
Carlos.
Hello. Good.
I think you have
for everybody.
Yeah. Welcome, Carlos. Okay, we're going to end this, and you guys stick around. I want you to talk to each other. Okay, thank you very much, Richard, and we'll see you next week. Thank you very much for an excellent presentation.
Thank you, Doctor.